Everyone, Einstein's Eyes, Carl Rosen, oculoplastic neuro-ophthalmology fellowship trained, Anchorage, Alaska, the beautiful state of Alaska, where we have a real interesting energy. Hard to describe it. Come and visit. The summer's great, June and July. I wouldn't recommend February,
That's my
January.
question. It's April
or December.
21st. What's the weather like today, April 21st?
So I still have snow, but it's nice out. It's probably about 45.
Oh, that's not bad.
And yeah, I mean, for us, it's real pleasant.
Yeah, we got 50s today, so it's not that much better.
Yeah.
Norman, sorry to interrupt. So
No,
I'm
no
Jon
sweat.
Ditkoff. I'm a cornea specialist who also does general ophthalmology in northern New Jersey. Carl and I have known each other longer than a lot of you out there have been alive. We met each other in our training at Albert Einstein in the Bronx, where we got our feet wet and really learned everything there is to know about eye disease. And we kept our relationship even though we're on the other side of the world from each other. And I still haven't gotten to visit Anchorage. I can't wait one day.
Yeah, so John's going to come up. We're going to teach him how to go whale hunting and seal hunting.
Yeah.
So today we're going to talk about an interesting topic that's really more for the Bronx or urban areas, but it can happen anywhere.
Yeah.
And it really revolves around addictions and things like that, but specifically focuses on eye-related complications of crack cocaine. And what do you see? When John and I were residents, we actually had a crack cocaine eye. And I believe a paper was published. I think it was Ron Sachs that published that paper.
More than one case, yeah.
Yeah.
Multiple cases.
And really interesting things happen with crack cocaine eye. But I'm going to let John talk about it, and I'll chime in. And before we start, I do want to share an image.
Yeah, that's pretty scary.
So that is crack cocaine and the crack pipe.
What we're not going to discuss is how to smoke crack. We're not going to.
No. That's not what we specialize in. We don't advocate that. But here it is. But this is what an eye can look like. A crack cocaine eye can look like. And John, let's hear your comments.
Yeah. So as Carl mentioned, I mean, this was something that we did our trainings 30 years ago. So it was early 1990s, right? I mean, that was really and crack cocaine was exploding back then. And this went undiagnosed in many clinics. People would come in with a few different presentations. So they would either come in with just an irritated, inflamed eye that looked dry or irritated, or they came in with what we call a corneal ulcer, which is an infected cornea. So what we're seeing here is a really, really red, inflamed eye that's infected, and that white ring is an ulcer. So there would be many eye doctors in the world that if they saw this person come in, they'd think, oh, is this from wearing contacts? Is this from a fungus that got in their eye while they were mowing their lawn? I mean, there'd be so many things we would think about as doctors with many years of experience. The last thing in our mind was crack cocaine. So that's where it became a really difficult diagnosis. And I guarantee there's plenty of eye doctors, even nowadays, that would probably not even realize that this is from crack, that they would have just treated it as an infection and not known what caused it. So what happened was in the clinic, what we realized when we were doing very careful histories is we started to see that there was a cluster of patients that all seemed to have the same presentation. They came in with what we called neurotrophic keratitis. So they had a cornea that was inflamed and dry looking, and it didn't have normal sensation. It almost like the nerves were damaged. And on further questioning, we realized that these people were smoking crack. And then there was another subset of people that were coming in with infected eyes like this one, that similar type of thing. But this person that came in with a red painful eye, you would think they'd be really uncomfortable. They walked in the clinic, they were barely uncomfortable. They didn't even feel it because what happened was they were smoking so much crack, the smoke was going, so they'd be sitting here with a pipe. The smoke was going up. Guess what happened? The smoke was passing right by their eyeball. It was numbing their eye. So they didn't feel what damage it was causing to their eye. They had no sensation. And in fact, one of the patients I remember distinctly was he would get so wasted because he wasn't just crack. He was so out of it. He went and touched his eye and he realized, oh my God, I can touch my eye. I don't even feel it. He started like just touching his eye and like scratching his own cornea. He basically caused the own damage with his own finger. So it's a pretty unusual disease. Before we got in this thing, I'm thinking, do people still smoke crack cocaine? Unfortunately, there's still hundreds of thousands of people doing this. So this is not only a good video for people out there. We all know you shouldn't do crack cocaine, but this is good for all the eye doctors out there, because if you see a patient present with neurotrophic keratitis, ulcer, problems like that, you got to think about this in your differential. You got to do a good history to find out if they smoking crack.
Yeah. So Jon, again, the vapors are culprits. They're part of the disease process, the pathogenesis. And remember, cocaine is an anesthetic. We use it.
It's one of the best anesthetics. Yeah, it's really
right.
numb.
I mean, yeah, it goes back. Freud used it in the 19th century. So,
but a lot of people, when they do cocaine, they get a kick out of. They'll put a little bit in their teeth, and they feel it get numb. So some of these people were getting a kick out of it, numbing their eye.
Right. So as an anesthetic, it would allow these folks to rub their eye for whatever reason, and that would exacerbate the damage of the corneal surface. And once the corneal surface is breached, think of it as your moat or your castle defenses are gone, and now the bacterial hordes can come in and chew up their cornea and cause an ulcer.
Yep.
And if an ulcer gets really advanced, it'll destroy that cornea, and it can get into the eye, ruin the eye. And it's possibly not salvageable. So this is really dangerous.
The average person who scratches their cornea, they get a little tiny scratch. Carl, what happens? They come running into the office because they're in horrific pain. But these people had small scratches to start. They didn't even feel it.
Right.
They didn't even know they had a scratch. And like Carl said, not only did they not have a scratch, if it bothered them, they just started to rub it and they still didn't bother them. And they had no protective mechanism to go to a doctor or to use lubricating drops or to put antibiotics in. They just kept getting numb, and then finally it got worse and worse.
Right. So really what we're promoting and support is, consider this: if you're a healthcare specialist, if you're a physician, optometrist, if you're a nurse practitioner, a PA, primary care doc, remember the differential diagnosis for a corneal ulcer includes crack cocaine.
Yeah.
I wouldn't think of it number one, but certainly consider it on the differential. And I think that's valuable
I agree.
as far as this video goes.
The other thing is, the initial treatment might be similar in that you're giving them antibiotics, but you have to realize that they're neurotrophic. So the cornea needs nerve fibers to regenerate and heal itself. If they're neurotrophic and they have nerves that are not functioning normally, their healing mechanism doesn't work well. So these people thin out their cornea. They're more likely to perforate their cornea. They're more likely to scar. So you really need to be much more aggressive about not only treating with antibiotics and infection, but getting the cornea to heal.
Right. So, I do oculoplastics and neuro. I would send it to my cornea partner, fellowship trained cornea partner for this. It would just be safer and better hands. But including it on differential is the first step. And then considering, I would consider, discussing or addiction intervention.
Yeah.
It's a difficult conversation. That's another topic, but that's also part of the whole perspective and conversation. Jon, thanks a million again. Thanks to the audience, and we'll see you guys on the next one. Thank you.